Good morning, dear student. I'm Daria Saeed. I'm discussing an overview of endocrine physiology. Of course, our lecture is very short for discussing whole endocrine physiology or for even reviewing them, but we will discuss the most important points of the hormone. So, the objective of this lecture is to review the general feature of different types of hormone and to review the most important hormones and their feedback mechanism, and to review the hormones that affect growth, to review the stress hormones, and some daily facts about our body hormones, to discuss important hormone physiology that related to the diseases. What are general features of hormone? Why it's important to know the features of hormone? Why important clinically? Peptides are hormones that already made and stored in the vesicle and activated upon stimulation and released when needed. So this is important feature. If you know that peptide is stored in vesicle, and you all know that they are rapidly released and they also have rapid action. So this is important to know how rapid the peptides are and how rapid their action. So this is vesicle that peptide stored in it. So they are made whenever there's stimulus, they released immediately. And all peptide or all brain hormones are the peptides. Not all peptide from brain, but all brain hormones are peptide. This is in order to remember. While lipid soluble hormone, they are synthesized whenever needed. So when stimulated, then they synthesized and not stored like the peptide hormones. Except we have an exception, which is thyroid hormone. Endocrine physiology, why it's so complicated? Because you have some exceptions. Like this example, thyroid hormone, it is stored, but its storage not like that of the peptides in the vesicle, but it's outside the cell in the colloid. In the colloid here, inside the thyroid follicle, so not inside the cell. And all peptides are dissolved free. That's another feature of the peptides. They are dissolved free and they have short half-life in plasma, except insulin-like growth factor. كواتا peptide كان هرميان short half-life يعني زورزونا من البلازما. This is also an important feature about the peptide that you have to know. Except insulin-like growth factor. It's protein bound, so higher affinity for protein, not like the other peptide, so they have longer half-life. هر هورمونی با پروتینو ببستره یا افینیتی تا زورتر با پروتینو half-life اکی زیادتر به و موایکی زیادتر لپلازما امینتو. While generally peptides have short half-life because they do not need protein to transfer them. They dissolve freely in water in plasma. Unlike lipid-soluble hormones, opposite to them, lipid-soluble hormones have their specific binding globulin, which is called. That's why for this hormone we hear these terms: free hormone and total hormone. So the free hormone is the one that is active and causes feedback inhibition. This feature of the hormone is important, very important clinically. You have to remember why, because as we said, we have free hormone and total hormone. And as you know, the free hormone will not change. Only the total hormone changed in case of the change in the level of plasma protein. So whenever change in the level of the plasma protein due to any condition, for example, physiological condition like pregnancy, which goes increasing the estrogen, and so increasing the total protein, the total hormone will affect it and increase, not the free one. And whenever there is decrease in the hormone, in the proteins, in the plasma protein, like in case of high androgen, in the liver disease, in some types of medication, what will happen? There will be decrease in the protein. So any condition cause decrease in the plasma protein, either due to loss from the kidney or due to liver disease. The plasma protein decrease, so the binding protein decrease. What will happen? It will cause the net decrease in the total, but the free will return to normal. How this happen? You proceed this in the previous years. In the first year in the S2 in the metabolism module, and you know that at the beginning, of course, the free will change, but later by the negative feedback, the free will return to normal. So what is change is the change in the total hormone. What's important about that? Why we have to know that? As you know, for example, a pregnant female come to you and you did investigation and you found that her total, you sent her for total thyroid hormone, and you found that her total thyroid hormone is high. So can you say that this pregnant female is thyroid toxic or has hyperthyroidism? No, of course not. Although it didn't depend on a single investigation, but you have to send free hormone for this patient. Of course TSH is the most important one, and if you send for thyroid hormone, you have to send to the free one for the pregnant female. Why? Because in the pregnant female, because of the high estrogen, there will be change in the binding protein, the hormone, the total hormone look high, while the free one is normal. And which one is most important? The free one. As you said, the free one is active and it goes the negative feedback. So the free one should be normal. If the free one is normal, no problem with the TSH, so the patient, this pregnant female, has no problem. And that's why in these conditions especially, it's better to send the free hormone for the investigation, not the total one. As you know, hypothalamus and anterior hypothalamus is an important gland. Hypothalamus is a biological clock. It's important in the circadian rhythm, and it has several hormones that affect the pituitary hormones. And pituitary hormones, you know, is a master gland. You know, pituitary is it's a master gland. Why? Because it releases several hormones, and these hormones all control most of the body glands and functions, and they affect most of the body cells. How? First come to the anterior pituitary hormones, and you know there are hormones that released from anterior pituitary, like growth hormone and prolactin. And growth hormone causes growth, you know, and prolactins affect the mammary glands, which is the exocrine glands, not endocrine. So these two hormones of the anterior pituitary act on the cells other than the endocrine gland, while we have hormones of the anterior pituitary, which are TSH, ACTH, LH, and FSH. These are called trophic hormones or tropic hormones. Trophic hormones means that they affect or control hormone production of other endocrine glands. So as you know, TSH act on or control hormone production of the thyroid hormone, ACTH on the adrenal cortex, LH, FSH on the gonads, which are all endocrine glands. So whenever a hormone has effect on other hormones, it's called tropic, and trophic for increasing the cell size and increasing in the growth and production of hormone by that particular glands, endocrine glands. We have several hormones from hypothalamus. They are either stimulatory, like growth hormone, releasing hormone, and so on. And we have also hormones that are inhibitory, so they control pituitary hormones through either stimulation or inhibition. And also hypothalamic hormones under the control of pituitary hormones by negative feedback. We have a condition that which is adrenal hypofunction. You diagnose the patients mostly by their features. One of the features or sign that you see by inspection on the patient, you can see there is darkening of the knuckles or the darkening of the gums or of the skin creases. You can see this is in adrenal hypofunction. Why adrenal hypofunction or Addison disease cause this darkening? First, as you know, when we say adrenal hypofunction, so what will happen to cortisol? Adrenal cortex cannot produce or cortisol decrease. So as you know, we have this feedback mechanism. This is an example of feedback mechanism that we have: hypothalamic, pituitary, adrenal axis. We have also hypothalamic pituitary thyroid axis, as you know. Hypothalamus normally release corticotropic releasing hormone, which act on the pituitary to release ACTH, adrenocorticotropic hormone, which act on the adrenal cortex to release cortisol. And cortisol negatively feeds back on anterior pituitary. So whenever cortisol increase more than normal, in order to control its release, what will happen? It negatively feeds back on anterior pituitary to release less hormone and return it toward normal, and return the activity of the cells under the control of cortisol toward normal. And also it has another feedback mechanism, negative feedback on hypothalamus to prevent further release of CRH to control cortisol again. Okay, what will happen here? Adrenal hypofunction, cortisol decrease. Decrease in the cortisol cause what? This feedback inhibition on anterior pituitary not happen. This feedback inhibition on the hypothalamus not happen. So what will happen? There will be high CRH, high STH by pituitary. They try to increase cortisol, but they couldn't. Again, cortisol is low. No negative feedback, so high CRH, high ACTH. So ACTH become very high level, and this high ACTH level causes this skin darkening. Of course, there are several other features and symptoms and signs that the patient that have. This is one of the features. But why it causes darkening? This is present in your lecture. You can read it. What about posterior pituitary hormone? Posterior pituitary hormone, as you know, we have antidiuretic hormone and oxytocin. Both of these hormones are important. Let's come to oxytocin. Oxytocin, as you know, released from the posterior pituitary hormone. It's synthesized in the hypothalamus, but released by posterior pituitary hormone. What's the function, or what are the function of oxytocin? It causes contraction. Contraction يدوشت. First, contraction of myoepithelial cells of mammary glands. So it causes milk ejection. Ejection of milk to the mouth of the baby. So milk ejection, not production. It also causes uterine contraction. So contraction of myoepithelial cell and contraction of the uterine. Both of them is related to the mother and the baby. Uterine contractions during labor in order to make labor easy for delivery of the baby cause contraction of the myometrium and its delivery, and this is important, as you know. لوانه سكرتان لبو به زورتان کسیکتان اگر لادم نالی بو به و تویانه چی بو هلواسن جانی صناعی چیه؟ اکسیتوسینه کاتی خوی لایه و پیوسته منالی به جانی صناعی اکسیتوسینی بو هلواسن synthetic oxytocin in order to cause uterine contraction and delivery. And you know, oxytocin is also called love hormone. It's associated with emotion. What about ADH? Do you know why ADH or anti-diuretic hormone called critical hormone or critical to life? any hormone that affects blood pressure and affects circulation, and its absence or abnormality cause shock and death. So it is called a critical hormone, or it's critical to life. What's the function of ADH? Antidiuretic hormone is cause antidiuresis, so prevent urination or decrease a large volume of urine production. So it causes water reabsorption through aquaporin. Chiaka, water reabsorption. But another effect of ADH is in higher level, the same ADH that causes water reabsorption, in higher level there will be an additional action, which is vasoconstriction. It causes constriction of blood vessel. So both of these two effects is important for control of blood pressure and blood volume, and so it's important. That's why if there is very little level of ADH, what will happen? There will be loss of large amount of fluid or water in urine. So there will be hypotension, shock, and could cause death if it's not treated. So I have a question for you. What are the stress hormones? Do you know what are the stress hormones? You may hear about catecholamines as a stress hormone, adrenaline, noradrenaline, cortisol. But do we have other stress hormone? Can you call other hormone as a stress hormone? Can you give me a few examples, please? Stress hormone and their effect on metabolism. We can say growth hormone, cortisol, glucagon, and catecholamine. We can group them under the stress hormone. Why? This, of course, I made it like this. I grouped them under different names in order to make you to remember easily. Why these four hormones? Why glucagon and growth hormone is grouped or categorized under this stress hormone? Because all of them كألين stress يعني stress all of them increase during stress. Stress, anxiety, exercise, pain, أمانهم reaching stress, and all of them increase during stress, during pain, during infection, during anxiety. There's only growth hormone. It's also increased during sleep. This is only particular for growth hormone, specified to growth hormone, increased during sleep. All stress hormone raise blood glucose and free fatty acid level. كاتا أماكي كتير لفيتشارة كاني شي stress hormone كان كوتمان هاو بشلة بيني أنا همو stress hormone كان glucose و free fatty acid برسا كانوا بوشي. As we said, they are present or increased during stress because we need these nutrients to be available during stress. بيسمع بيعتبر energy بكار يعني إنكو عدا blood glucose و free fatty acid برزا كانوا. The single biggest difference in their effect are their effect on protein. بس كاري عن لسا protein جهازا شون. بيرما growth hormone شيلا protein of course it causes growth, that's why increase protein. What about cortisol? You know that cortisol decrease protein because it causes breakdown of protein. What about catecholamine? Catecholamine has no significant effect or negligible effect on, or no effect on protein. What about glucagon? Let's see glucagon. What happened? What glucagon do to the protein? It didn't cause breakdown of protein glucagon, but it moved amino acid and use them to make glucose. So use amino acid in gluconeogenesis instead of protein formation. So make less amino acid to be available for protein formation. And this effect is under the permissive action of cortisol. And under permissive action of cortisol. What's permissive action? Permissive action of a hormone is an action of the hormone that this action is not its effect due to its effect, but they they permit other hormone to do this action. كاتي مالين كورتيزول permissive action هي لسر جلوكاغون. يعني كورتيزول لري جلوكاغون وأبيته هو يويك أمينو أسيد بقربة جلوكوز أمين جلوكونيوجينيسيس بكا نكخوي أو بكا وقت كورتيزول يشكي بروتين تكشكانا بلام هاني جلوكاغون يا كجيبكا كأمينو أسيد كان بكا با جلوكوز كاتا كورتيزول مشاغبة هربا ورازينا بخوي بروتين بريكداون كان على بروتين جلوكاغونيش بروتين دروسكا واكا جلوكاغون بروتين كم كاتا وبيكا بجلوكوز. So this is the permissive action of cortisol. And what about the terms of anabolic and catabolic hormones? Anabolic hormones like growth hormone, insulin, thyroid hormone, androgen, these are called anabolic hormones. Why they are called anabolic? Because they cause formation of protein. So any hormone that causes protein formation, they have major role in growth, so they are called anabolic hormone. While catabolic hormone cause protein breakdown, or they are catabolic, they cause protein breakdown like cortisol, glucagon, and catecholamine. So all stress hormones are catabolic except, I think you know which one of them, except growth hormone. Growth hormone because it causes protein formation. Let's come to another important gland, which is called adrenal gland. And you know adrenal gland have both adrenal cortex and adrenal medulla. Adrenal cortex and adrenal medulla. So let's see what are the hormones that are released by adrenal cortex. They are aldosterone, cortisol, and adrenal androgen. And adrenal medulla release epinephrine and norepinephrine, or we can say adrenaline and noradrenaline. Aldosterone, and these hormone, of course, you know, aldosterone, cortisol, these are adrenal cortex hormone, mostly under the control of CRH, hypothalamic CRH, corticotropic releasing hormone, and pituitary ACTH. CRH كاركات سر ACTH adrenal corticotropic hormone will affect adrenal cortex hormone, but aldosterone is not under the control of ACTH like other adrenal hormones. زيادة خوي cortisol under the control of ACTH. androgenيش كما كلاجر control يأتي بلام aldosterone has the major stimulus for aldosterone secretion is not ACTH but angiotensin 2 and potassium level. You know aldosterone renin angiotensin aldosterone mechanism, how angiotensin 2 cause release of aldosterone. So aldosterone, we can say it's also a critical hormone. We need it for survival, you know, because it also cause affect blood pressure and blood volume. How? You know, without aldosterone, large amount of sodium and water loss and cause shock and death. Because you know what's the function of aldosterone? It causes water and sodium reabsorption. Without cortisol, let's come to cortisol. Cortisol has several permissive action. cortisol sta functionی اکفت که خوی اخوانین باشه کش من باس کرد بالام permissive actionی زوری هیا یکی لوانه او بک باس من کرد وتمان چیه کات کارکات سر glucagon permissive effect هیا. Another permissive effect. Without cortisol, catecholamine do not exert their normal vasoconstrictive action. يعني شيء يعني catecholamine has vasoconstrictive action. This is the action of catecholamine. While without cortisol, cannot do its action perfectly, efficiently. So it needs cortisol to present in a normal level for catecholamine to do its action. That's why the cortisol has permissive effect on catecholamine on their vasoconstriction. Also, Without cortisol, body will not able to readily mobilize energy. This is also has permissive action on the catecholamine. And what maintain blood pressure, so is aldosterone and norepinephrine from synapses. So for controlling of blood pressure, the most important one for the long term is aldosterone, and for the short term is norepinephrine that released from synapses. Adrenal androgen is less effective than testicular androgen. It is normally in normal amounts not so important, but when its level increase, it become excessive, very large amount release, become pathological, then it's important and very important to be diagnosed and treated, because it leads to congenital adrenal hyperplasia. You'll take it later. What problem happened to these patients? Another few questions. Did you hear about adrenal diabetes? What's adrenal diabetes? Why is it called adrenal? Why adrenal diabetes? In which way cortisol increase plasma glucose? So we said adrenal diabetes because cortisol, or adrenal cause, when there's increase in cortisol, there will be decrease in the or increase in the glucose. Let's see how cortisol cause increase in the plasma glucose. You know what's diabetes? Either insulin deficiency or insulin resistance, diabetes mellitus, and both of them cause increase in the blood glucose because of decreased glucose uptake into the cells. And why adrenal diabetes? Or because cortisol also causes increase in the plasma glucose. Let's see how. So the most important glucocorticoid is cortisol, act to mobilize energy. Let's see what's the effect or mechanism of action, or what is the action of cortisol. Cortisol, as we said, is stress hormone. It causes mobilization of these free fatty acids and glucose from the cell and go to the blood. So it increases glucose, it increases free fatty acid, because it also causes lipolysis, less lipid formation, decrease protein level by protein breakdown, only liver and plasma protein formation enhanced. And it has permissive effect on glucagon, and it has permissive effect on catecholamine also. The major effect of cortisol, how cortisol causes increase in serum glucose. One of them is, as we said, under the permissive effect on glucagon. So by gluconeogenesis, by potentiating glucagon, and this will occur in the liver. That's patient with liver disease. What will happen when the patient has cirrhosis? They mostly have hypoglycemia, because this effect, this gluconeogenesis not occur efficiently. Another cause of increase in the serum glucose by cortisol is decreased uptake of glucose to the tissue. So it is opposite to the action of insulin. That's why when there's high cortisol, this will cause adrenal diabetes. It's called adrenal diabetes. So keep blood glucose up and give it to the brain, because this is the major effect normally, because brain using glucose only. This is important normally in the normal level, but when it's become high, it become like that of diabetes. Okay, and cortisol is under circadian rhythm, and ACTH also under circadian rhythm, follows ACTH. What will happen? It will become very high or peak at about 6 a.m. and it's very low at about late evening or night. This is important. Cortisol prepare you and give you breakfast when you wake up. يعني وليك active ببعنيان خلاصتي energy هوشتكي باشا لكيا باشا لكاتيكا كإما سيركيتين رزمي خمانتي همون منتك نيابي يعني جيتك ما نابك شكا جاران خۆتانزان زوو ئەخەوتن و زوو هەڵاستان بەڵام بەداخەوە ئێستا بەهۆی ئەم سۆشیال میدیا و ئەم ئەلکترۆنیا توشتا زۆر بەماوە ئەمەلیاتەکە درەنگە خەوین و تا درەنگ بخەوی خراپترە بەس مەگەر خوا بزانێت چی لەم سەرکەیتیان ڕزمە هاتووە ئێستا. Physiological effect of aldosterone. Aldosterone effecti چییە؟ Aldosterone وتمان NA water absorptionەکە کەواتە water retentionەکە بۆ blood pressure باشە. But when it reabsorbs sodium, it will secrete potassium and H through the kidney tubular cells for absorption of Na. That's why if you see a patient which is alkalotic hypokalemic, you should expect primary hyperaldosteronism. Why? يعني جي alkalotic hypokalemic. alkalosis يعني H زور ون كردوا hypokalemic potassium زور ون كردوا كأم دوي بيكوه بو بير ما بوشي بجي primary hyperaldosteronism. aldosterone يوانا زور بوا صوديومي retention كردوا بوا صوديوم reabsorptionەکە potassium H زور تر كردوا لا normal. The feedback control of blood pressure by renin angiotensin aldosterone system. You know aldosterone is important for blood pressure control. And let us see how. By renin angiotensin aldosterone system. What causes renin secretion to cause angiotensin 2 and aldosterone secretion? These renin released under 3 effects. One of them is decreased blood pressure or when there is decreased blood pressure, blood flow decrease to the afferent arteriole. When there is decreased blood flow to afferent arteriole, renin will release. Decreased sodium delivery to macula dense of distal tubule. This is another stimulator of what? Of renin release. كاتا sodium delivery كما بيبقى tubule renin release. Another factor that has effect on renin release is sympathetic stimulation through beta-1 adrenergic. So sympathetic stimulation also causes renin release and in order to increase blood pressure, of course, toward normal. So what will happen when there is a renin release? You know, angiotensin 1 change to angiotensin 2. Angiotensin 2 has 3 important effects. One of them is vasoconstriction. One of them is aldosterone release and water and sodium retention. Another one is ADH, antidiuretic hormone. So by this, it will return blood pressure back to normal when there's hypotension or hypovolemia. What about adrenal medulla? Do you think adrenal medulla is also critical to life? Or adrenal medullary hormone are critical to life? You know, adrenal medulla release epinephrine and norepinephrine, and it's important for fight and flight during stress, during sympathetic activation, you know. Most of the hormones that are released from the adrenal medulla is norepinephrine, epinephrine, adrenaline. Norepinephrine is mostly released from synapses. Only 10 to 20% of adrenal medullary hormone is norepinephrine. Another important feature about catecholamine is it's very difficult to measure them in the blood because of the short half-life. You know, we said why important to know the feature of hormone. In order to, when you send a patient to investigation, you cannot send the patient for catecholamine in the blood because they have very short half-life. They remove very easily within seconds, minutes in the blood. That's why it will not remain in the blood when the patient got to do investigation. So what should we do? We have to either measure its urinary level or measure its metabolite, which is metanephrine. It's called vanillyl acid, which is a metabolic end product either in the plasma or in the urine. We have to measure. When, for example, there's pheochromocytoma, in which there is an increase in the number of cells of the adrenal medullary cells, chromaffin cells. There will be high amount of catecholamine. In order to investigate and diagnose, we have to send the patient for these metabolic end product. So, can we live without adrenal medulla? Yes, we can say yes. We will become diseased, lethargic, and several problems we will get, but it is not critical to life like that of the aldosterone ADH that we discussed. Why? As you know, the synapses and norepinephrine has effect on alpha receptor on the blood vessels and cause vasoconstriction. So norepinephrine has higher affinity for alpha receptor and cause vasoconstriction. So the effect on vasoconstriction is mostly through norepinephrine, not epinephrine. And norepinephrine is mostly, as we said, released from synapses in a form of neurotransmitters. That's why even if there is no adrenal medulla, we can live. It's not cause death, but we become lethargic and diseased. So cortisol cause protein breakdown, as we said.